Hi, Mohammed Al-Mala here. I want to share with you a surgical video of a routine cataract surgery. I share this video primarily for educational purposes, primarily for surgeons who may be in training. This video shows my technique for routine cataract surgery. We've already made the initial incision and put in preservative-free lidocaine, and now we're injecting visco to fill the anterior chamber. You can see we've got a really nice dilation here. I do this in almost all my cases. I use 0.12 forceps to grab the paracentesis and really stabilize the globe for when I make my primary incision as well as perform the Capsulorhexis. So for my Capsulorhexis, I start out with a Cystitome. I make generally one continuous motion and raise the flap with that motion as well. And then when I go in with my Capsulorhexis forceps, we complete a continuous curvilinear Capsulorhexis. We want to achieve a large enough Capsulorhexis so that we're able to easily remove the cataract, but at the same time, still have enough anterior capsular edge to overlap the edges of the optic of the intraocular lens we're going to place. So here we do a hydrodissection, and we tent up the capsule in trying to achieve a cortical cleaving hydrodissection, so a minimal cortex after we remove the nucleus. Phaco probe goes in. We're using the Alcon Centurion peristaltic system, and then we use a second instrument to perform a horizontal chop. I use the same mode throughout my entire case, and I start out in quadrant removal mode. And we've got a pretty good crack. We've got a very nice rotation. It really does rotate easily. And make sure the crack is complete. And then we start chopping the first heminucleus. Now we have two quadrants. And here we have a very nice rotation. It rotates and spins very easily. And now we crack the second heminucleus. And now we already have four quadrants. And we can immediately start phacoemulsification, still in the same mode. If you notice here, I have my second instrument already behind the nuclear pieces. I'm not really sure I need to do that, but I think it gives me just a sense of safety here. And so we see that we really do have a nice rotation. It spins very nicely. And I'm taking out this third quadrant. It looks like the fourth quadrant is still a little bit partially attached. And it really does come out very nicely. And so we see we actually do still have some cortex left. Our cortical cleaving hydrodissection did remove some of the cortex, did separate some of the cortex temporarily here, but nasally we still have quite a bit of cortex remaining. So I'm going to go in with irrigation aspiration, and we're going to use that to remove the remaining cortex. If you notice there, I use BSS to irrigate out the paracentesis just in case there was any nuclear pieces that were stuck in there, that they would come out. And then we use the IA to remove the subincisional cortex. And then even though we've done irrigation aspiration, I still like to polish the posterior capsule, and I almost always use a terry squeegee, this instrument right here, which is a cannula with a silicone tip, and I use that just to irrigate the posterior capsule and remove any remaining lens epithelial cells that may be there. Oftentimes I find there is some cortex attached, and so that helps to get rid of that. And then my provisc technique here, I'm putting in provisc to fill the capsular bag, but I injected to the right and to the left of the wound first, and I've found that really helps to centralize and help me not leave any lens material or lens pieces behind. We inject the IOL, so when I'm irrigating out when I'm inserting the provisc, I'm injecting that directly into the anterior chamber angle, both to the right and left of the wound. So we've got the IOL in place. It's spinning nicely here, and I'm using IA on a high aspiration setting to remove any viscoelastic. I go behind the lens in almost all my cases, and then I align the haptics of the IOL nasally and temporally. And we can see we've got good anterior capsular overlap. And now we hydrate the main wound first, and then we inject BSS through the paracentesis to inflate the chamber, then hydrate the paracentesis. Then we check for pressure inside the eye, make sure we leave it at a nice pressure, and that's really about it. And we want to check the wounds, make sure they're watertight, not leaking any fluid. Thank you for watching. I want to share this case, routine cataract surgery. Please leave any comments, questions. Let me know your thoughts. Have a good day.